Hi, and welcome back to November's webcast for the Sisterhood in Surgery. Time is just flying. I can't believe it's November already. But today we have an extremely important topic. We've never actually done this topic in the past, but it's very common, more than you think, about intimate partner violence. And so today we have very seasoned guest, I should say, somebody who actually was chair here previously, Dr. Barbara Bass, Dr. Carrie Sims, and Dr. DeAndrea Joseph, and of course my wonderful co-host Dr. Palma Shaw is here. And so it's going to be a great show. Remember, this is a live show, so you can join from the web. Go to polev.com, text, enter DeBakey, or join by text, text DeBakey to 37607, and we will try to get your questions answered. Again, it can be anonymous. We don't say anybody's name or email on that. So I will start with the introductions. Dr. Barbara Bass, everybody knows her. She wants me to keep her introduction short. I'm not sure how I'm going to do that, so here we go. She is Professor of Surgery and Walter A. Blodorn Chair of Administrative Medicine. She serves at George Washington University Vice President for Health Affairs and also the Dean of the GW School of Medicine and Health Sciences. She's an international leader, as you all know, in academic surgery. She is known for her contributions in surgical education innovation and surgical workforce policy. She has trained hundreds of surgery residents and medical students, and she was previously the chair of surgery at Houston Methodist. And she's actually the founding director of Mighty, which I was in all day today. It's a beautiful facility for training, robotics, endovascular open cadaver setting. It's the U.S. first in concept simulation-based education and research facility. The purpose was to retool practicing surgeons and healthcare providers to evolve procedural technologies. She is also the first cohort of women to be promoted to Professor of Surgery in the U.S. and internationally. She has been a visible role model and passionate advocate and sponsor for equity for all who have historically had limited access to exceptional careers in surgery and medicine. She has many leadership roles, and this is where it's a very long list, but she has been an advocate for increasing awareness of this important topic. Welcome, Dr. Bass.
Glad to be here. Thank you.
Okay.
And I also am extremely excited about this topic. I did not know how big an issue it really was. And then I was just so thankful that our guests have agreed to enlighten us today. So I'd like to introduce Dr. Carrie Sims, who is a trauma and acute care surgeon with a research focus on intimate partner and gun violence. She graduated from the University of California, San Francisco School of Medicine in 1995 and completed her general surgical training at Massachusetts General Hospital in 2003. She subsequently finished fellowship in traumatology and surgical critical care and obtained her PhD at the University of Pennsylvania. Dr. Sims has been an active member of the American College of Surgeons and an integral member of the Intimate Partner Violence Task Force. And as a member of this task force, she created the Intimate Partner Violence Toolkit that can be found on the ACS website and is dedicated to helping women find the resources they need to overcome with the intimate partner violence. Welcome, Karen.
Thank you so much for that kind introduction.
And our last guest, Dr. DeAndrea Joseph, hails from the nature island of the Caribbean, also known as Dominica, not to be confused with the Dominican Republic, as she is quick to point out. She has wanted to be a surgeon from the age of 7, after her mother reassured her that her unusually large hands were not something to cry about, as other children had suggested, but the hands of a surgeon. Never be bullied. She is an acute care surgeon and is board certified in general surgery and surgery critical care and trauma. She completed her surgery residency training at Brown University and her surgery critical care fellowship at Adams Cowley Shock Trauma at the University of Maryland. She's over 20 years of experience in the management of critically ill and injured surgical patients and is recognized nationally and internationally for her expertise in intimate partner violence. She's a member of multiple national organizations, including AAST, American College of Surgeons, Society of Critical Care Medicine, and New England Surgical Society. She's the co-chair of the IPV task force of the ACS, which was started by past president Dr. Barbara Bass after the tragic death of a colleague from this. She is author of multiple peer-reviewed articles, book chapters, and editorials, and has given multiple invited talks about this topic. She's dedicated to education and training and has served in multiple leadership roles, including as program director and clerkship director. She's the proud recipient of the Golden Apple Award from Cooper University Hospital for her commitment to teaching. She is the past chief of trauma and acute care surgery at NYU Hospital, where she was recruited to successfully develop their trauma program. She received Trauma Medical Director of the Year Award from the American Trauma Society. Her commitment to healthcare has taken her to work internationally with the government of the Commonwealth of Dominica, where she is serving as a consultant to help develop their emergency surgery system. Welcome.
Thank you, and apologize for just jumping in right now. And we do multiple different things all at once. It's the curse of being a female trauma surgeon, a female surgeon in general. But
Yes.
Thank you very much. I'm very happy to be here.
So I thought we could start off really just talking about what was the purpose of even developing this task force. What was Barbara, maybe start. I know you have some real important experience with this that triggered that.
Thank you, Palma, and thank you all for really hosting this particular topic. It's one that I learned about the hard way, and yet I think it still remains one of those conditions where general awareness, particularly among professional women, remains inadequate and rudimentary. I will say that my awareness of this is like many others, I often had sort of a stigmatized view of intimate partner violence and in fact a biased view of intimate partner violence. This was something that happened to others. It wouldn't happen to empowered women. It wouldn't happen to a brilliant transplant surgeon. It wouldn't happen to a professor. It wouldn't happen to a person of wealth. This was I didn't know that was sort of part of, that this is a condition that affects anyone. And sadly, during my time when I was in Houston Methodist, we lost one of my women faculty who fit all of those descriptors. Brilliant, powerful, generous beyond belief, a role model in every respect, a brilliant transplant surgeon. And she was murdered by her husband, who then also took his own life shortly thereafter. This is often a double murder-suicide event, at least half the time, about half the time. And I think that one of the things first after recovering from this kind of stunning loss and just wondering, how the hell did this happen? What is this about? I started learning about this condition. And I also, not fortunately, but at the moment, I happened to be the incoming president of the American College of Surgeons. And I think it's important when you have a platform to use it for something you think is right and important that maybe will have some impact in things that you care passionately about or that you think really readily need to be addressed. And this one happened just right before that and really completely transformed the purpose of my presidential year. Yeah, there were lots of other things too, but this one really drove me to think, man, we got a problem here. And of course, as soon as you scratch the surface, you discover that there are many, that this is a condition that could impact any couple. More women are impacted than men, but it's not restricted to women. And I will say that I've learned so much since then, and had the opportunity as president of the college to say, okay, well, we're going to make a task force on this at the American College of Surgeons. And we're going to gather people together, women primarily, but women and men both, who care about this project, and will actually come up with some actionable programs and tools to disseminate to our vulnerable groups, particularly vulnerable groups in our profession, about this condition and the steps the opportunities we have as caring for each other as colleagues to intercept and intervene and educate, and to come up with some real actionable items, which Dr. Sims was part of that first task force and has been so instrumental in that. But the bottom line is I learned a lot, and I used the platform that I had to get this started, but boy, the work that's gone on has been fabulous, and I think has had genuine impact and continues today under the current leadership of Dr. Andrea Joseph. So I hope that tonight, those that are on this website or webinar will realize that this is a condition that can affect anyone. And the unique spin that we want, not the spin, the unique focus we wanted to bring to our work is not to address intimate partner violence writ large, that big problem that we know exists throughout our society, but really to focus on the professional people that are at risk for this condition, who otherwise don't necessarily seek help, who don't have access, who don't utilize the tools in social services, for example, that maybe others might feel more comfortable using. So this is really about professional people who are stuck in these intimate partner violence relationships of all different forms, which I hope we'll have a chance to talk about, to spread the word, seek to destigmatize, encourage people to seek help, and train others to learn how to provide that helpful guidance and intervention.
Harry, I was wondering how long you've been involved with the task force, and then I actually, Barbara led into it. What is this exactly? Is it just physical violence? Is there emotional abuse? I mean, how many forms does this really have?
Yeah, no, so I've been involved in the task force since its inception. And I think I too was stunned by the passing of the transplant surgeon. Because I think, it really shocked me and really made me confront my own myths about this phenomena. I think as a trauma surgeon, we're taught to recognize intimate partner violence, see it as part of interpersonal violence, but it was always a phenomena of the other. And it was hard, it was shocking for me to believe that a woman, a transplant surgeon, who we all know are they run the hospital, for God's sakes, that they're really tough and that she could have been a victim of it as well. And so when Dr. Bass put out a call to have folks, join this task force, that's when I did. And I think you raise a really great point about is this just violence? Is it just, physical violence? And I think it's important to think about intimate partner violence not as just physical violence, but actually as a one partner trying to exert control over another partner. It's all about control. And so that violence can be anything from actual physical violence to sexual violence to economic violence to like a psychological violence. They attempt to control many aspects of someone's life, their ability to meet with friends, to interact with others. It's about secluding them, and it can take on all of those kinds of different nuances. It doesn't always have to be a woman who is punched. It can be someone who berates their partner or forces them into sexual encounters that they would otherwise not want to have. So it's really about power and control, and they use the perpetrating partner uses all forms: children, pets, finances, words. Like it's really a spectrum of disease.
Can I just read some stats that I thought were very eye-opening, just so everybody that's watching, understands how common this can be. But nearly 1 in 4 adult women and 1 in 7 men report being a victim of IPV in their lifetime. It is the leading cause of serious injury and death to women ages 18 to 24 in the U.S., and victims are at increased risk of developing major depression and post-traumatic stress disorder, attempting suicide, and abusing drugs and alcohol. Women exposed to IPV have a 5-fold increased risk of suicide, and 40% of women homicide victims are killed by an intimate partner. Wow, that's almost 50%. I mean, that's very
Shocking.
Yeah.
In some studies, it's actually one study, in earlier studies, is actually as high as 62%. So it ranges anywhere from 40
To
to
60%. Wow.
62%. And if I may,
Please,
one
yes.
of the reasons I got into this actually was I come from a culture where it is not unusual, in fact, for that this has changed over the last 20 years. And although we were one of the first countries in the world to have a female prime minister, it's a very patriarchal society. And the idea of a man physically hitting a woman is not really looked upon, at least at the time I was growing up, with much, oh my God, I can't believe this happened. It's more like, oh, all right. And I had personal experience with this, that being, not in my immediate, but in my family, but not immediate. And I knew it was wrong at a very young age, but didn't fully understand it. And when one of my positions, I got involved with intimate partner violence and began to understand it a little bit better. And like everyone on this panel, was very surprised that it wasn't just a group of people. Even though I had been exposed to it, there was still sort of, it happens to someone else, right? And one of my very first patients as a junior attending was a female who had fallen down the stairs, ultimately broke her neck. And what I learned later on after the fact was that she had been pushed by her spouse. She ultimately died. And so I had little bits and pieces. And so when I wanted to become more involved and I sought advice from a mentor, Dr. Brett, and then that's how I caught onto the IPV task force. But this is something that I do believe is so under-recognized, the importance of it is so, I still don't think we fully understand it. And the first time I gave a lecture at my most recent institution, I tell people this, first time I gave a lecture about IPV and the importance of our role as a surgeon, I was told, you sound like a social worker and you shouldn't do that talk anymore. Obviously, I didn't listen to that, because that's not what I am good at. And so I think we need to start. I think Dr. Bass says something really important. We recognize it in all patients, and we obviously have this responsibility, but really looking inward and starting to recognize where it also affects us is how we're going to gain power and leverage over this phenomenon and understanding why it happens, right? Several studies suggest that uh, the likelihood of becoming an abuser starts with having witnessed it as a child. And so, where we work is to break that cycle. And I'm not just talking about an abuser, but also becoming a victim. When you think that that is the norm. I also recently gave a lecture. I was a named lecturer at the University of Arizona in Phoenix, and I gave a talk on IPV, and one of the surgeons stood up and said, "I was that victim," and spoke to the audience, and it did not involve physical abuse. It only after she said she was leaving, that's when it actually became physical. And that is where I think we have to really emphasize, because the physical aspect of it, the tragedies that we've seen with the recent death of a resident and the medical student, that's the end of the cycle. It starts with again, it's about control, but it starts with the behavioral, it starts with the emotional, the financial, and we could go on. I could talk about this endlessly. Um, and that's where we, I think, need to break that cycle and intervene before we get to the point where it becomes a tragedy, as it has in the situation we described earlier.
I do think it is sort of one of the, we've seen behavioral health become less of a stigmatized condition of late with the pandemic. People are much more open to seeking support for anxiety or depression or other forms of mental health that happens to people. And thankfully, we're beginning to see those barriers broken down. But this remains, I think, a stigmatized condition, and one that we therefore don't seek help for from others. And part of our awareness campaign in the college is to make it very clear that this should not be a stigmatized condition for you, that you can, but there is effective intervention, there is help available to you, and and it's really important that you recognize the potential, ghastly harm that will come if we refuse to seek help in one way or the other. But the other part of that as well is that we, as our sisters in surgery, if we want to call it that, or sisters in whatever it is, we need to be aware of we need to be aware of the condition so that we can recognize in our colleagues when something's just not right. And there are very real things that you can see. It's often sort of a change in their willingness to be engaged with others, to just talk more, so there's an isolation that often develops pretty early on. For those these days in the days of cell phone, you'll often find that a victim is getting excessive phone calls from somebody or other. And what's that about? Well, that's somebody who's really tracking their every move and keeping an eye on them and pressuring them and threatening them. And we need to be able to recognize those signs. I didn't know that sign, but I know it now. And I think it's really important that we educate ourselves of the signs and symptoms of this condition, and particularly when we note a difference in someone who we've known well. We also need to recognize that a group that is particularly vulnerable, this is our residents. This is a condition of sort of that age 25 to 45 kind of. That's the really, really high risk zone. And another high risk period is a period of pregnancy and immediately postpartum. High risk zone for what has been an abusive pattern to escalate into something more deadly or dangerous. There's other simple little things, like if somebody has a black eye, they've been hit in the face until proven otherwise, period. That is like a pathognomonic sign that someone has been struck. It's not, oh, they fell and they hit their head on the counter, blah, blah, blah. They were hit in the eye. And they may not tell you that, but you got to ask. So there's that kind of signs and symptoms that we all need to be aware of, and then we need to have the courage and the tools to reach out to those people that we nearly know and care about. And I know in part of your materials you have the safe mnemonic there, and I think we should talk about that as a tool that everybody ought to just keep in the back of their mind at all times. When you're even just beginning to have a suspicion that something's just not right.
Why does why do you think the isolation happens? Is it because the victim is embarrassed? Is it because they don't want, I mean, I guess it's all those things, or they don't want to cause,
It's often a demand. It's often a demand of the
Yeah.
partner who
Okay.
says, "Get here,
Get
be
here.
here now,"
Yeah.
and uses it as a threat. So there's an imposed social isolation that often will come, and sometimes it's wanting to be close to protect children, or to protect pets, or to protect other assets. It's a very complicated, but really ugly, ugly situation to be in all around, and nobody wants to admit, especially. And there is a literature that particularly powerful women
Yeah.
are embarrassed to be in such a relationship. Well, I can't, and I can take care of this because I can take care of really
Right.
difficult things at work. I can deal with this, but no, you can't sometimes. So it's important that we all just be mindful and aware when things are not right. We got to get help, and there's lots of ways to do that. Carrie, maybe,
So-
or Carrie, DeAndre, maybe somebody could talk about safe. I think everybody needs to have that language, boom, like that.
Yeah, no, I think it's let me just pull it up here because I have to say that I think you're absolutely right. I think that just to echo on something that you said, I think group of the people who are most at risk in our surgical training are really those that are young, because they don't have a lot of control over their schedule. And so when someone else is controlling their schedule, the partner gets crazy. They just feel like they're out of control. And so they want to control more. And as a resident, you really have no control over your schedule at all. And I also think that the perpetrator really somehow manipulates the situation. Residents and newer attendings already feel insecure about how much they're, not giving back to a relationship, and that they're giving so much to residency and training and their jobs and their patients, and that they can really be manipulated into thinking that they're not doing enough for the relationship. And so I think that becomes part of the controlling factor. And so most, even if you're not a surgeon, most victims of intimate partner violence, that victimization begins by the age of 25. And so, that's prime time for training, prime time for insecurity, prime time for feeling like you are you're not successful, like all sorts of the psychology of training coupled with the psychology of the perpetrator can really make a situation in which the person doesn't even recognize that they're being victimized, that they feel like they're the problem, that they're not a good partner because they're not giving enough time, and that this person who is like they just love them so much kind of thing. Do you know what I mean? So I think it can be very warped, a very warped sense of responsibility and giving back to the person. But clearly, it's not acceptable to harm anyone. And so, physically, emotionally, verbally, what have you. So the safe thing I'm going to just pull up here is a set of 4 questions, in that you are, do you feel, safe in your relationship? That's the first one. Do you feel safe in your relationship or not? The second one is, do you feel, abused or argue a lot? Is the A. The F is
Or afraid. Afraid
yeah,
is
or
also
afraid.
Afraid.
Yes, thank
Yeah,
you. Yes,
right.
or afraid. And then the F is, remind me what the F is, Dr. Bass?
Family. You said you're family aware.
Oh, yeah,
Your
family aware.
friends, friends are family
Friends and
aware.
family.
And then the E is, do you have anywhere to go or an emergency plan should
Right.
things get crazy? So, so I think it's, it's important to, and maybe those questions don't necessarily, come across in an average conversation. But if you notice someone's behavior has changed, for example, a resident that you was previously a hardworking resident showed up on time, did their job, was conscientious, and that's changed, what's going on. It could be anything, honestly. It could be intimate partner violence, it could be drug and alcohol abuse, it could be depression. But all of those things are things that we as educators and attendings need to sort of ask about. Or, if someone, just to Dr. Bass's point, where the person is stalking them or calling them excessively, that's not normal behavior. Does the resident or friend ever go out with the other colleagues? That goes to that isolation. And if those things are sort of raising some red flags, it is okay and actually encouraged to just, get a cup of coffee and say, hey, is everything okay? Like, are you, what's going on? You seem different and I want to be there for you. And then, go down that conversation about, is anyone, hurting you at home or making you feel afraid? So it doesn't have to be the first question that comes out of your mouth when you're meeting with a colleague or a trainee, but sort of getting, opening up that space and sort of creating that space to have a conversation about it. And many people will say, no, everything is fine. Number one, because they are embarrassed or, that it's a sign of weakness or what have you. But often people don't recognize that type of behavior isn't normal. That if they've been brought up in an environment where people argue and throw things and, verbally and physically abuse each other, that's just marriage or a relationship. And that's not necessarily, they may not necessarily perceive it as abuse. And so I think, sometimes people don't see themselves as the victim, even though they're going through that kind of behavior. It takes 3 to 5 times of trying to leave a partner, and the average time it takes to actually separate from that relationship is 7 years. So, it's not going to be a one and done kind of thing. It's just about creating space and a safe place for that person to be vulnerable with you.
But I guess
I wanted, I'm sorry.
I was just saying, it must be so difficult if children are involved because, it's one thing if you're living with somebody and that person's the emotional abuser, they're watching the clock, they're stalking you, they're like, why are you so late? I'm going to call the Childhood Protective Services and report you as an unfit mother because you were operating all day and I'm stuck here with the child, et cetera. I mean, and then where do you go? They're in your place where your stuff is. You're working 80 more hours a week. You're trying to be a good mom. And then you've got this person there that's just manipulating you all over the place. And then it takes so much strength to actually leave or get them to leave somehow and feel safe enough in doing that.
Mm-hmm.
And I wanted to emphasize a couple of things that was said. The fact that it isn't a one and done. And when you recognize that there are changes in your colleague and you've made the decision to ask how things are, as I think someone should, that you should really do a follow-up, because it's very easy to go, well, I've done my part and I've asked, and so that's okay. And sometimes you may need to reach out. If it's another resident, you might need to reach out to somebody more senior to assist with the process, because this person is not necessarily going to open up immediately. And the reasons that were very clearly elucidated, shame is a huge part of it. We all talk about imposter syndrome sometimes. And to a certain extent, a lot of people experience it, including myself. But imagine what the resident does, the resident who is trying to figure out if they're good enough. So the last thing that that person is going to want to add is the fact that they're experiencing those kinds of things. So it's so important to do follow up. It's so important to create the space as described that that person can feel vulnerable. And I've also posed that question to some of my peers, colleagues, people I've spoken to. Imagine what it's like having a way of life, right? And then all of a sudden, in order that you move on from this abuser, you have to give that up in some circumstances. And so when you have encountered a colleague, a resident, or someone who you're senior to, and you find that that person, well, why aren't they leaving? It's important to understand not to pass judgment as well. I still think that we haven't fully understood what that phenomenon is. Why one person who is seemingly in control, like the cases we've described, suddenly succumbs to another individual. So I don't even think we're fully understood the whole thing. So being careful not to pass judgment when you find that, well, this is so obvious, why isn't this person leaving, is really important to us as educators and colleagues looking at other people who are experiencing this. So I just wanted
to expand on that, I think that is really an important part, really important point, Andrea, and it is really, really difficult as you're asking about, Palma. I think the idea that you're going to pick up and go, or you're going to kick somebody out, how are you going to do that? I mean, the actual logistics of this are very difficult, and yet it's especially difficult if you're not talking to anybody. If you could at least seek some sort of partnership with somebody, a colleague, a friend, a social worker, your physician. You can talk to your doctor about this. I think so you don't navigate it entirely alone. I think it's really important, and women like us don't necessarily want to reveal that we're in the middle of some crazy thing like this. And it takes great courage to do so. It takes great courage, number one, to leave, but also takes great courage just to go ahead and reach out for help. And that's why I think it's so important that each of us are that little nudge sometimes that we'll make that initial outreach. And I can't tell you how many people when I was a mother, I had this little one chair in my office. I can't tell you how many people I used to call into that and sit down in that chair. You sat down in that chair, you were going to get asked about something that I was worried about. Whether it was right or wrong, I was worried about it, and I was going to talk to you about it. And every once in a while, something really needed attention that the person was just previously unable to articulate the need. And I do think that is why this safe thing, we all just need to have that in our brains. It's easy to start with that. But then again, I think the other thing is that we are not the professionals who can actually help navigate the support once a person has kind of recognized the situation they're in. I mean, this is a whole different level of professional expertise that person needs to have access to. And it's true, most of it does fall into the world of psychiatric social work or social workers or others who are professionals in this. They're actually going to recognize it in a heartbeat. They're going to know all about it. We're acting shocked about this. For them, this is bread and butter, like appendicitis or like a cold leg or something, I mean, it's really, they have expertise that we don't. And our job is to just let somebody kind of recognize this is not quite right. Maybe I better, and get them to that professional expertise. And most of the institutions where we work will in fact have an employee assistance program that will have access to professionals that we can direct our people to. The hardest part is getting them to take that step to go ask for that help. And that's where we as sisters and brothers need to step in.
I think, it's so important for that person to feel safe, that they're not going to feel judged, that they're not going to, and Harry there was a webinar about 2-3 weeks ago where we talked about the legal aspect of things. How do you navigate that? Because it's not simple. It is not simple. We sit here And we go, well, yeah, this person's being abused. They just need to do that step. It is not simple. And it is so important putting the person in contact with the right people that they need to be in contact with. And our role is to provide support, is to point where they need to go and be that shoulder that they can lean on, not even necessarily cry, but lean on. Yeah, we're very bad. I mean, I epitomize not being able to ask for help. Carrie can tell you. So, we're not good at it. So that's why you have to go to that person and say, I'm here.
We have
One
a,
one of the best access, to resources is the National Domestic Hotline, and so you can sort of call up and get some counseling. I think the EAP. I think getting that person who is experiencing this psychological support is probably the first and most important thing, because it isn't easy navigating getting out of a relationship. In fact, it's the most lethal time of that relationship is when they're going to be leaving. The partner, the perpetrator, often will kill the person at that point. It's the most lethal time. So it's really important that if you are going to leave, that you do not share that information with someone who's an intimate partner perpetrator. Keep that to yourself, tell your friends, have code words, and figure out a plan and a strategy. Keep your documents separate, get a, different, some
Bank
resources.
account.
Yeah, get a burner phone, like whatever, to get away safely. And I think it's hard because like you can't run away from your job. Do you know what I mean? Like
yeah.
your partner knows where you work. So unless you're going to be like, graduating and moving across country or getting another job, which, is an option, but people can track you down. And I think that's where it's really important to go to law enforcement or get the professionals that Dr. Bass is talking about so that you can get restraining orders and, letting the hospital know who this person is. Because it is like if they leaving is really lethal, and sometimes that lethality transfers to the people that you work with. 50% of all mass shootings are associated with intimate partner violence. So it's not just you, it's you and your possible children, your friends, your coworkers. And so really having a thought out plan for safety is super important.
We have a live question. Is there a checklist to make someone recognize what they could be going through if they aren't sure?
Good question. I think there are on the website of our website, you can find, specific examples of what's happening. One of the questions that we have, is about lethality, and there is something called the Danger Assessment Score, which you can go online, Danger Assessment, and click through a bunch of boxes, and it will predict, what is your chances of actually getting murdered by your partner, with some accuracy. So, I think there are questions on that website as well. But yes, there are on our website. You can find the questions that would be suggestive of intimate partner violence. And again, it's not just the physical violence. It's actually like, verbal abuse, financial abuse, sexual abuse, that kind of thing.
Does it usually start with emotional verbal abuse and then it just escalates over time? Is that the more common
Yes.
scenario? Okay.
So escalation is kind of par for the course. Like
Okay.
it starts off with controlling the person's behavior, who they speak with, where they go to, and then it gets eventually to physical. But it's important to note that it doesn't necessarily always follow a expected standardized pattern. And one of the things I like to tell people is, in addition, the website is very, very informative and very helpful. But if you're asking the question, you feel uncomfortable, I think it's important to, even at that point, to seek out some expert who may be able to help. Because if you are, then something's not quite right, and that's it may not be the full blown manifestation of IPV, so to speak, but there is certainly something in the relationship that is causing you to have some question. And I think it's useful at that time to even seek out what the resources
That's an
are
excellent
on the
point.
website.
Excellent point.
Are
Yeah.
there characteristics, hopefully, I mean, once you're in the cycle, I imagine it, like just like everything y'all said up to this point, very difficult to leave, takes 7 years, multiple parties involved, the, anxiety of like, what if they hurt my workplace, my friends, my family? Are there characteristics of a perpetrator, like before it gets serious, that could maybe warn you, like, hey, maybe I need to get out of this before it gets too serious?
So, with the danger assessment score, I think if the partner ever threatens to kill you or your children or your pets, that's actually a huge red flag. If your partner ever attempts to strangle you, that's a huge red flag. And if there is a gun in the home, that increases your risk of actual murder as well. So, those are, I think there are characteristics. Does your partner, are they angry and explosive? Do they prevent your movement? And then if there is physical violence, the things that predict the lethality are the very close proximity things like strangling or holding a gun to the
And
other person.
choking. Mhm.
Yeah, strangling, choking. So those are highly, highly predictive of lethality.
But even early on, I think, like Linda was asking, I think that we're busy, we're surgeons, we're operating, we're doing like a lot of serious things going on every day in our life.
Mhm.
And then you get someone in your life, and maybe you don't realize that they're a narcissist, and then you don't realize that they're kind of cutting you short and kind of separating you from your friends. But why are you on the phone so much? Why are you talking to them? And then you realize you can't talk on the phone to your family or to your friends, and then you become isolated, and then they get angry at you, then you become afraid. So it's like it's like a ebb and flow. It just pulls you. It's like the undertow in the ocean, right? You're under the water before you even realize then you're and
Yes.
you're like treading water trying to get out, and you don't know who to talk to because you're afraid to talk to people at work, or if you do talk to people at work, they don't know how to react, and they didn't watch this webinar, so they have no idea what IPV is, and they definitely don't know about the ACS website that has all these valuable tools on it.
Yes. So I think you've hit the nail on the head. And that's why we have to, discuss this broadly and widely so that if that person finds themselves in this sort of undertow of a relationship in the guise of one partner exceptionally loving the other one, which is the way that they usually frame it. They just love them.
Love bombing.
Yeah,
Love
that they
bomb.
just love them so much. And you're right, there is usually this sort of cycle of violence where like there's this honeymoon phase, then there's a buildup, and then there's an explosion, and then there's a reconciliation, and it keeps going through the cycle. And that whole explosion just becomes more and more disruptive and disastrous for the victim. Like it's, maybe it's that they're controlling their every movement first, or really wanting to know where they are first. They have a big explosion that can escalate into physical violence the next time go around. But or verbal abuse. I think verbal abuse happens way more than we know. And like I said, people fight in their own, like, their families fight. And if they see that as normal, loud voices, throwing things, slamming doors, punching walls, like that's all perceived as normal, then they're not going to see in their partner that's like not normal. Like that's
Yeah.
crazy. So it just may be one of those things where like, you talk to people and have a conversation about it. But I think this is how we break the stigma, is by having these webinars and talking about it amongst women.
One of the things the task force did, which I think was important, is to try to educate our residents as well about this. And I think we do have a real opportunity in our graduate medical education programs. In medical school, I can say as a dean, there's like one question about IPV on the whole curriculum. It's just not something, there's so much else we're packing in. We don't spend as much time on this as we can in our residency programs, and particularly those that have exposure to this condition as part of their regular, regular work. But one of the things that we did, that this task force did early on, and Patty Newman was at play here too, there is this curriculum for first-year residents, and that is a national curriculum. And one of the scenarios was a surgery resident who came to the ER having been struck by her partner. And it was a really wonderfully elaborate but complex scenario that made you think about, well, gee, we know the perpetrator too. What are we supposed to do here? It really made you think about the very real lives that some of our trainees are living, and how you, as a physician or a colleague or a supervisor, could step in to help here. And so I think we do have many of those kind of things that we're now getting distributed through most of our residency programs. I think the current work of the task force is really looking to potentially partner more with the ACGME and with the ABS to incorporate these questions. There was an IPV. I just took for the heaven knows how many times recertification thing, or my MOC exam. But believe it or not, there was a question about IPV on there. I was thrilled to death to see it on there. Yeah. And I can't even
That's
remember
progress.
It's progress, and I think that it's risen to that awareness. And so however many of we old general surgeons are taking that every 2-year program exam, there was one on that today, and you had to read the article to know the answer. So I think we're getting the word out that this is something that can happen to anyone. And I'm going to say again that the work of this task force is very specifically focused on us, we surgical professionals. We can't change this condition in the whole world, but we can take care of our own. And we need to take that as our first step and work with all of our partner organizations. I know SBAS now has a IPV working group. I know that, of course, the college does. I bet we need other organizations to, step into that and just have a little committee every once in a while, or a program, a slot on their program, which I know some of you will actually run. Go ahead and put some IPV on there about our professionals, ourselves, as opposed to about that poor soul that comes into the ER after getting beat up.
Well, you're absolutely right. I think by actually focusing on ourselves and making ourselves comfortable with it, if nothing else, that will be a step towards, changing the world. Because I think ultimately we all secretly want to change the world. So I think by putting a light on ourselves and making ourselves feel more comfortable, how we recognize this, I actually think is a step towards, the rest of the population.
But this is probably not just a US problem. This is probably a global issue, right? And
It is.
so what we can do is the new society, the International Society for Women Vascular Surgeons, which was started by Linda Harris, and she's the president, I'm the vice president for that. We can certainly bring this up to the executive council, and I think if we can, take this on as well, and with all the women, and make everybody aware, and then in a global way make people aware. I think it's important.
No, you're absolutely right. This
Absolutely.
is not a purely U.S. problem, and in fact, societies that are more patriarchal tend to have higher rates of intimate partner violence.
Yeah.
But we're
And I
ahead,
think
you know,
it's,
as far as
yeah,
the
please.
women in vascular surgery, the SVS, we're actually way ahead of Europe as far as the women, a number of women in leadership roles, and a number of women feeling empowered, at least in the vascular society. So I think there is a lot of work to be done. Sorry.
That is true universally of Europe. I hate to tell you, but Europe is it in terms of academic medicine and surgery in particular. Man, we're 20 years ahead. We really
Yeah,
are.
it's quite interesting. I think
Thanks.
it's
I love
also
Europe.
important. I want to put a little plug in there for the 1 in 7 men, because I think sometimes when we speak, because we're used to we're a little better at being more open about this, the female surgeon, than the male surgeon. We sometimes neglect to mention that men also are victims, and men also, yes, it's less so than the female victims, but it's an important thing to mention. I think the last webinar that you had, uh, Carrie, the person who caught on there was actually male. One of the questions was from a male surgeon talking about what his wife had done to him. So I just want to mention that we recognize that everyone can be a victim, and that when we, as the educators, approach somebody, that we're sensitized to everybody, regardless of gender or how they present. Yeah.
I do think that women are greater risk for lethality.
Oh, absolutely.
Yeah.
Absolutely.
By
Data shows that.
really
Bar none.
significant factor,
Yeah.
and we can't lose sight of that.
Yeah, absolutely.
Well, y'all
Absolutely.
are doing amazing work. Palma and I will take it upon our personal agenda to reinforce this, because yes, we are both, more so Palma, high up in the vascular societies for sure. And I mean, just from 2019 till now, or maybe 2017, 18, but recently I have seen such a change in our program alone. I mean, we have not approached this topic yet, but just in diversity, I mean, social issues this show alone, right? This would have never happened 10 years ago. Would never happen. Nobody would have been ready for it 10 years ago in vascular. And so the fact that we are moving fast in the vascular world, at least I feel, Palm, I don't know how you feel, but I think this needs to be a topic for us as well in future society meetings.
So
I
I know
would greatly appreciate that. We would
Yes.
greatly appreciate that.
So I know we only have a few minutes. I guess maybe some closing comments about, how people can take action, or, last thoughts you want to have.
I actually, I'm going to jump in because I wanted to, you said that this would not have happened, and I want to say that it's Dr. Bass made this happen. I understand that the series of events led up to it, obviously horribly tragic, but there are many things that could have happened. You could have turned inward. You could have said, oh, this is horrible, and just walked away. But she used her voice to make this, be a center of a center focus of one of the many things that the ACS does. And so one of the ways that people can do things, all the organizations, I think, reach out. I like to think the American College of Surgeons is sort of the big umbrella, and by pulling different organizations in, and really sort of always having this as a topic at the clinical congress, at different forums, was the way that you continue to educate. And that's one of the ways I think people can help, and the people in leadership positions really trying to push that narrative forward can, I think, be really instrumental in making this a central focus.
Excellent.
I can also say that, we all teach residents too. We all are in academic surgery. So we have a bigger voice in many of these things than other surgeons who are in practice, just without the benefit of a department around you or an institution around you, and certainly without raising the next generation. And I think that one of the things that early on happened in the task force was the creation of a PowerPoint that you can show to your residents. It's there, it's all ready to go. And I do hope, and it can be modified specifically however you like, but it's pretty well completely there. And to encourage everyone, one of the faculty members, to give a talk about IPV once a year to your residents. That's a pretty simple way to get the news out there. But we are still, I think, in the information and awareness stage. Once we get that, then maybe we can get the safe thing in our pocket for everybody, and then we will actually develop effective, referral tools to really begin to help people that need that help so desperately.
Maybe they need to make an app, download an app.
There's an app for that.
Is there an app? Is there an app to make the app?
Yeah, one of the things that happens-
There is an
I
app.
think that's brilliant. An app that has like a toolkit, which is one of the things that Stephanie and I are talking about, creation of a toolkit and maybe an app that can filter
That's
that when it
safe,
disappears.
Yeah.
those
Yeah,
safe questions for sure.
yeah.
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 Well,
So
thank you.
I just want to echo what Dr. Urbasa said about, making this be part of the grand rounds, the educational things for the residents, grand rounds for the faculty, at least once a year. And, if even if it means like co-opting some space in a wellness or health focused grand rounds. I
Being
think
called a social worker
what's that?
Being called
or
No,
being
no,
called
no.
a
I
social
mean,
worker.
aside from being called the social worker, I think it's sometimes, if you have a grand rounds that said, oh, we're going to talk about intimate partner violence, 50% of your faculty aren't going to go. But if you have one that's talking about, health, and sort of tucking it in there as well, then I think you'll get a broader audience. But the point is, we have to start talking about it in these, open areas and open ways. I have been stunned after giving these talks about how many people come up to me and said, that happened to me. That happened to my sister. That happened to my friend. This happens a lot, and we don't really talk about it. So just even getting it out there so that we start having these dialogues, I think, is critically important. And then the second thing that I wanted to say is that it really is, if you see something, say something. I know it sounds so trite, but in order for us to actually impact our colleagues and our trainees, we have to start asking people. And when you talk to victims and survivors of intimate partner violence, they're not upset when someone asks them. In fact, they actually express gratitude that someone cared enough to actually ask them if they were okay and if things were going on, and to create that safe space. So even if the person doesn't disclose that there's something going on, they know that they can come to you and you will help them find the experts that are necessary to help them. So just really ask. It's a sign of love. It's a sign that we care about each other. Just ask.
Just
That's all.
ask. I
That's
like
all.
that.
So I think that we have to wrap up because the studio's giving us the wink. But this is just a huge topic, and congratulations to all three of you and everyone you're working with. And I want to give a shout out to Dr. Anton Sadawi, who just texted me because he watched the show too. He's a huge supporter and incoming president of the American College of Surgeons. So we are very thankful for his time as well. And thank you so much. Everybody
Thank
should
you
go to the
so
website
much.
and check out the task force webpage.
Thank you for doing
Thank you
this.
so much for hosting us.
Good night.
It's our pleasure.
Thank you, everyone.
Have a good night.
Thank you, everyone.